consultations. The solutions are very simple. We have a patented device called Stethoscope, and this patented device is currently available in the United States and in India. As some of you are from India as well, you might appreciate that we are integrating it with the largest synchronous diagnostic telehealth platform called eSanjeevani. And the device will be available to a larger population of almost 1.5 billion people. What this device does is uses a simple phone or a tablet and a very passive, very low-cost stethoscope that uses the microphone on the device itself, and the patients can send their auscultation audios to a remote doctor. This way, because of the auscultation, the remote diagnostic capabilities are increased. In addition to this, we also have a device called AutoCape, which uses the back camera so that the patient's ear, nose, and throats could be inspected remotely. We have a virtual clinic, which we call Yodoc EMR, and the trusted and renowned doctors are available who also see the patients within their office. So we try and make these one-to-one matches which carry forward into the real world, and they don't just remain in virtual world. We have various partnerships with University of Ottawa, Miro AI company, and eSanjeevani, like I mentioned earlier. Now, touching base upon the medical imaging is also a very important aspect of diagnostics. We integrate our EMR with medical imaging with various vendors in the US so that the labs can send the data directly to the EMR, and the doctors can look at the medical imaging results as well as the images themselves through the EMR, which are all HIPAA compliant and FDA approved. We have a competitive advantage compared to many other telehealth players. There's at least 5 to 6 big names called TytoCare, Amwell, Teladoc, ZocDoc, and MD Live, where Velify plays in 2 quadrants, which are shown in this chart, where we provide a synchronous diagnostic integrated with EMR, as well as integrated EMR with simple audio-video diagnostics as well. And this way, we achieve a significant advantage over many other players and increase or make the healthcare outcomes better, increase doctors' revenue, where by charging multiple CPT codes, and which is as good as in-office consult. So multiple advantages include the time saved for the doctors, time saved for the patients, traveling back and forth, waiting in the waiting rooms, and making the in-office consultations available to the folks who truly, truly need it, who cannot be seen over telehealth. And that just brings tremendous amount of efficiency to primary care delivery. So far, we have raised over $700,000 in revenue, achieving milestones with an extremely low burn rate. We have over 200 doctors registered on Velify in India and 2 in US, and we are increasing our footprint in US. And we are not limited to India and US. We are open for the entire world. And the website is called velify.com. We've already integrated with eSanjeevani, which is the world's largest telehealth platform. And this is our team. I'm the founder and CEO. Dr. Poonam Rane is our medical advisor. We have a regulatory and compliance expert, Tejashri, who's from University of Baltimore. Pushkar Jha is our cloud architect and CTO from IIT Kharagpur and Tufts University in Boston. And just to give you perspective, we have a star team. IIT Kharagpur is the same school from which Google CEO Sundar Pichai graduated. So we have a fabulous team in our company, and we hope to change the landscape of primary care all around the globe. And we are always happy to collaborate, So feel free to reach out to hello@velify.com or zunarkar@thehealthlink.com. And we would be happy to talk to anyone and collaborate. Thanks for the opportunity again, everybody. And I hope to learn some more things from the speakers which follow. But I also have to apologize. I'm on the road and I'll try to come in and out of the meeting. And that's about it. Thank you so much again.
Thank you, Sachin, for a nice presentation. Actually, for this telehealth or telemedicine, whatever you say, we are also pushing forward for this integrated EMRs in telemedicine. So this should not only be limited to teleconsultation, but there must be integrated EMR, and of course, if there are more diagnostic tools, then that will be wonderful. So thank you very much. Yeah. So, is there any question, comment for Sachin? Yeah, maybe. Yeah.
I did hear you speak to the clinical value to the doctor, but the focus was mainly on the finances. How do you see your product helping the patient?
So absolutely. So the focus is twofold. One is the finances by increasing the billable codes for doctors, and as well as increasing the diagnostics values that one could draw from a telehealth consult. With the auscultation, there would be many conditions which could otherwise will not be diagnosed through a telehealth, such as wheezing. You wouldn't be able to hear the heart and the lung sounds, especially during a telehealth consult. And same thing with the ear infection. With the AutoCape device that we talked about, the patient's ears, nose, and throat could be inspected remotely. And this is as good as an in-office consultation. This avoids, so for example, young families, they have kids running in the middle of the night or crying in the middle of the night because of an earache. Uh, they they have two choices. One is wait until the morning or go online, use the AutoCape. The doctor looks at the ears, sees an infection, and could prescribe the antibiotic right away. So patient is definitely the center of the entire innovation. The increased revenue stream is the side effect, as well as the increased efficiencies are also a very desirable side effect. I hope that answers your question, Professor. Thank you.
Yeah. Oh, thank you. Thank you. Yeah, from Telemedicine Society.
Yes, this is Abhimanyu. I just had a very simple question. What is the liability? What are the legal ramifications? Because I understand this is patient to provider, right? And what are the legalities in the US and India? And how, I guess, it would be adoptable in Nepal. So I'm just wondering if you faced any roadblocks in your journey. Thank you.
Excellent question. Regulatory aspects are very important. And in case of the Stetocape device, it's a class 1 device, which is a medical device, which is exempt. And for the otoscope, it's also a class 1 regulated device. So we have the FDA approvals which are necessary to market these products, which makes it, in terms of the legality, it takes care of the legalities. The other aspect is when you're doing telehealth consultation or any patient-related data for that matter, be it telehealth, be it EMR data, medical imaging, you have to abide by the US laws, which are called HIPAA laws, HIPAA. And these are for health data protection. So all the software infrastructure that we have developed is HIPAA compliant, which makes it in fact, acceptable to majority of the nations, including EU. EU has few other restrictions that come with, which we're not launched in EU, but they have a little bit more stringent requirements compared to the US. And we hope to fulfill those very soon. And I hope in terms of Nepal's laws and regulations, we do not have presence in Nepal as of today, but we would be happy to talk to legal experts or any leads that you can offer to figure out whether our HIPAA compliant infrastructure will be also legal in Nepal. We hope it would be, but every country has different laws, and we would need to navigate that as and when we launch.
Thank you. There's another team member. He just has one more question. So this data which comes out of the device, this would be compatible with any EMR which is also fire compliant, you would say? I mean, do you have smart on fire apps which are integrable with these?
Yes. So we have HL7 and FHIR APIs. More often than not, the EMRs do have the FHIR or HL7 APIs, and you could just push the data to any EMR. Currently, we are only integrated with eSanjeevani, as well as we are integrated with our own EMR, which is Yodoc EMR, and we are looking for partners. So as far as the FHIR standards are concerned, absolutely, we can integrate with any EMR that has FHIR.
Thank you. So, yeah,
One more question, if you don't mind.
Sure.
So help me understand this attachment that you talk about, the e-stethoscope and the otoscope. Is this a device that is plugged into the device that is connected in the network? And if so, is it plug and play type, or does it require an independent battery system to work on this?
A fantastic question. I'm glad you asked that. The devices are very passive devices. There is no active electronics on any of these devices. What I mean by that is it's a case. We call it stetho cape, like a Superman's cape. What it is a case for your smartphone or a tablet. And what that does is it uses the network, the internet of your phone, the Wi-Fi of your phone, to communicate with the outer world. So there is no Bluetooth, there is no Wi-Fi, it's passive, there's no batteries. It uses your phone itself, the microphone of a phone, as if it's your ear, and filters out the heart and lung sounds. I mean, I wish I could show it to you. If you don't mind, I'll just go get the device. Okay.
It's basically a software that uses the.
you are muted. Can you please unmute?
So the device is very simple. It's got a stethoscope, chest piece, tube, a case, and simply you put your phone in this. I'm sorry. You put the phone in it and then fire up the app. And once the app is turned on, all you do is record the heart and lung sounds. And the patient can also listen to the heart and lung sounds within their ears. And once they hear it, they record it and they send it to a doctor remotely. The same thing for the otoscope, we use the back camera of the phone. So in terms of the rural healthcare, where there is a lack of infrastructure or even sometimes know-how, where the workers may not know how to connect to Bluetooth, or workers may not know how to connect to Wi-Fi. But these days it's a given. People are much more intelligent, but nevertheless, sometimes you're technologically challenged, but not with this device. This device does not need any of that special know-how.
Thank you.
Thank you.
Thank you. Yeah, we are also waiting for this insurance coverage of this telehealth and regulation of these instruments or equipments that we are using. Thank you. We'll need your help. Next presenter is Dr. Akhila Kosaru. Please.
Thanks, everyone.
Yeah, hi. Please allow me to share my screen. Hope my screen is visible.
Yes.
All right, great. So firstly, I would like to just introduce on the topic that I'm going to speak about today. It's a very known term that we have been seeing since late very old times, which is called evidence-based medical practice. But of late, during the entire course of the time, it has undergone a lot of changes and evolution in terms of how evidence is practiced in medicine. And there are a lot of challenges that have been unraveled as well during this whole span. And when it started in during 1970s around, we have seen a very traditional practice where using a lot of intuition and the clinical expertise, which is very siloed, the medicine was practiced. But over the time, when there was in evolution happening on this, there is introduction of systemic reviews and meta-analysis that has happened over time, which has brought in a lot of data-driven decision making possible. And early in 2000s, we have seen a good amount of digital integrations taking place where electronic health records were widely introduced into the health systems. We have seen clinical decision support system, more or less rule-based systems coming into the picture, and large-scale databases have been formed, which has helped in getting the data captured. Somewhere around 2020s. Somewhere around 2020s, we have seen introduction of artificial intelligence in the practice. And we have seen a lot of predictive analytics, machine learning algorithms, and real world evidence that has taken a shape and has been introduced into the clinical day-to-day decisions. Why we are speaking about all these things is the reason because we as a company have observed a lot of gaps in the medical ecosystem where where around 1 in 3 cases have seen 1 in 3 patients have seen some kind of a care gap in their healthcare service that was provided. And when I say care gap, it could mean just a simple erroneous miss of a medication to address the side effects of a medicine, or it could also lead to worst possible outcomes for the patient, which is costing the life, which could cause the life of the patient completely. And when we are seeing from the doctor perspective, it could cause the complete license of the doctor to be lost when there is a small medical error that is happening. And there are multiple ways in which this can be controlled, but we believe that when there is practice of evidence-based care, which comes in with uh, three three main pillars, which is the research evidence that has been gathered over a period of time, and the clinician's expertise, and the third is patient values. All these three have to be in harmony, and unless this is in harmony, we will not be able to see the better outcomes for the patient. And this is quite possible using the best of the technological advancements that are possible today, and which is the artificial intelligence that we have considered to speak about. So, in the rural landscape, since Dr. Udaya has requested to bring in a perspective from the rural healthcare as well, I've done some research and studied that globally, we see 45% of population living in rural areas. And when it comes to India, it is more than 69% of population that stays in rural areas. And out of that, the highly preventable mortality is around 68%. In India, it could go around 80% of preventable mortality that happens in the rural areas. And astonishingly, 50% of these are coming from the non-communicable diseases. And the biggest challenge that rural India, at least today, sees is the availability of specialists in the rural settings. There is gap in adherence of the care. I mean, we have seen a lot of implementation of telemedicine become very popular and accepted during the COVID period, where there were thousands of consultations happening around. But nevertheless, we have also seen that the adherence of whatever medicine or a care that was prescribed to the patients was not very acceptable. And especially this is something that we have seen in the rural settings. The lack of awareness is one of the reason. There is also uh, a lot of complications that are preventable, but they are unknown to this population. And there is a lot of disparities as well that has come into light during this whole period, this whole equation. And there is a lot of possibility of uh, and in some interventions that can be benefited using the different telehealth platforms like Dr. Sanjay has showcased earlier. We have seen a lot of devices which can help in remote patient monitoring, integrated telemedicine systems. We see a lot of clinical decision support systems that can do more than rule-based system recommendation insights that could come into the picture and help at the point of care. Mobile health solutions, when I say mobile health solutions, these can be as simple as uh, an interface that is present in the in the mobile today, not necessarily an application in itself. It can also happen in WhatsApp. We have seen a lot. We have seen that UPI has opened opened up a realization to us, showing that accessibility of the technology is not really challenging for rural healthcare settings. Even a grocery store worker, even a vegetable vendor today in India especially, is able to operate UPI, which is just a smartphone interface. And similarly, we are looking at a system where this kind of a simple interface is provided in the healthcare setting, which is one of our product called Clinestra, which comes in as an interactive application that can help by looking at capturing the patient's complaints. It can analyze and interpret the patient's problems, create a digital profile of the patient, and help them in their local language understand what are the what are the insights coming in from the lab test report, and what are the next steps that can be followed using their prescription, when is giving them alerts and reminders in terms of using following the medical advice better, and also tracking the clinical outcomes of clinical outcomes from the prescription that is generated by their care provider. And whenever it senses an alert which needs a medical intervention, which needs a direct doctor intervention or a healthcare worker intervention, it immediately notifies the healthcare worker who is connected in the ecosystem, and they can perform an immediate intervention and help save a lot of lives. So these emergency care gaps are one way that we see that can be addressed using the artificial intelligence platform that we have built in. Um, so uh, Yeah. So I'd like to showcase some of the success stories that we have implemented during our using Oxidius, also bringing into light certain global success stories that has happened. So one of the case study that we have studied is Australia's Royal Flying Doctor Service, where just using a clinical decision support system on the real time, 40% of patient transfers were reduced in an emergency care setting. In India, my earlier co-speaker has spoken about the integration with eSanjeevani platform. It has been a huge success with over 10 million consultations that were completed, which was launched during the COVID period. And one of the good insight that I would like to share as a success story of Auxilius is that we out of our two products which are powered by our health intelligence platform, which is a patented technology understanding the medical context, and which can give the recommendations in terms of the point of care that is required for the doctors. We have launched two products. One is Astra AI, which is a learning and care assistant to the doctors. It comes just as a mobile application. It has been implemented in over 800. It has been implemented and being used by over 800 healthcare professionals as on today. It has answered around 10,000 plus medical queries so far, which comes in as a real-time decision support system. So there is very quick input that needs to be fed by the doctor in terms of the patient's insight, the complaint, the examination observations, and the system immediately analyzes and gives in the differential diagnosis with the clinical reasoning that is possible, and also has the capacity to suggest the next best action that can be taken for that particular patient. And this complete system is built over a patented framework that we have developed through Oxidius. And another system that we have is Clinestra, which is a care automation suite. This has multiple modules, which is a patient relationship management solution. It has an electronic medical record system. It has a care plan generator system. Multiple such components bringing together at different touch points of a patient and patient interaction with the system. And this comes in as more of an extended arm for the doctors in catering to their patients' needs. So it collects the information from the patient, summarizes and gives it in a very actionable format. It gives the recommendations once the decisions have been made by the doctor in terms of the possible drug interactions, missed dosages, missed diagnosis, missed recommendations coming into the picture, which could also talk about what are the possible complications by predicting real time depending on the patient's profile that is being created. And ultimately it is acting as a second brain for the doctor in giving an insight in terms of what is an alternative care pathway that a doctor can choose, whether conservative management is an option for this patient or not, by analyzing the patient's profile and giving the recommendations and output. We see that most of the time, there are a lot of doctors present in this forum here today. At least until a medical student finishes a decade of their experience, would not be very, very confident in taking any decisive actions, and they might be in requirement of certain guidance coming in from their peers, coming in from their seniors and professors in the ecosystem, which could help in validating certain decisions. And if the decisions are taken with limited information and limited capability of the doctors, could result in a lot of adverse outcomes. And as you can see, I have mentioned here today, we have negated 1300 plus adverse medical outcomes using the clinical recommendation engine. And today we are also conducting a pilot study with the government in the rural Indian settings on a smart AI companion for handling the non-communicable diseases in the country. And these are a few success stories that I could share. And most importantly, I would like to bring your attention that we have seen a lot of a lot of developments that happen over the last 5 to 10 years of time, where technology has enabled in better healthcare delivery. But despite of that, we are seeing a lot of fragmented systems in terms of technology as well. There is limited availability of data capture that is happening within hospital settings, and this data that belongs to one patient is not connected with the data that comes in at a different touch point within the hospital. And when this entire patient information is not interconnected, we are actually debilitating the system in terms of generating meaningful insights. And when there is a complete integrated health solution that takes into consideration different touch points of the patient with the system, and stitching them together, building an interoperability between the system using different devices, medical EMRs, and operational systems and all, we will be able to create a complete digital persona of the patient, which can probably help us in doing a lot of analytics and coming together with a lot of predictions that are possible in the healthcare settings. And this actually will allow us to identify the observe and collect the patient outcomes, provider satisfaction, and cost effectiveness of different modalities that we are working on as well, which would become very important metrics as we speak of evidence-based medical practice in rural healthcare settings. So this is me, and if there are any further questions, I would like to take them now.
Thank you, Dr. Akila, for the nice presentation. It was very much relevant, and most of the things that are covered, that is what we are presently discussing to develop this telehealth and healthcare. And some of the dilemmas like integrating with EMR, uh, telehealth or telemedicine emergency practices, those were dilemmas, and now we are being more clear on that. So is there any question or comment, Dr. Akila? Yes, Telemedicine Society.
This is Abhimanyu again. So, which is the more popular product, Clinistra or the other one? It seems Clinistra is more advanced, or it has been developed more recently. Is that true?
Clinistra is developed first, and that's the enterprise version of the solution that we have developed. But the health intelligence platform is a horizontal platform that can power any above power that's powering both the products. And also at the same time, the platform is also available as API as a service that is given for the existing health tech companies to utilize the intelligence as well. We are currently also partnered with certain health tech companies by giving us the intelligence. And when you ask me about the popularity of the device, I would say that we have seen a lot of adoption of Astra AI over the last 2 months since it has been launched. And within this 2 months, we have got 800 users, which is medical students and doctors using the solution. This mostly appears to you like a personal GPT and a personal search engine, which takes in the invalidated information from the medical literature, which is also from the 20,000 diseases that we have trained our platform on. And also it takes in the different 250 plus guidelines that we have added to this, and global guidelines, and also the research papers that are published on the topic that is being searched on. So every output that the doctor or the student gets from Astra is coming in from these three segments, which also cites the information that it is giving as well. It also comes with different drug interactions and everything possible. And because this is helping in a very quick go-to solution for this for the doctors and also for the students, we are seeing the good adoption of Astra AI, which is accessible in the Play Store and App Store. Even today, we have opened it for Southeast Asian market as well. Recently, we have a few of our customers from Korea, and we have around a couple of customers from Australia using this solution as well, apart from India.
Wonderful. So it's almost like a co-pilot for a doctor. It's like,
Yes, kind of, yes.
so if I may ask, and if it's proprietary, you don't need to answer. Is it like on RAG or CAD technology, or have you actually used those kinds of training modules?
Yes, I'm not a technical founder. We have another technical founder of the company who handles this, but I would be able to answer that we use RAG technology to use our to build our models.
Thank you. Wonderful, wonderful. So nice.
Thank you.
Thank you. Are there any other? So if not, next is Dr. Sanjeev Upreti. He will be presenting on AI in healthcare. I would like to request him first to introduce himself. And presently, he is with me here.
Okay. Hello, namaste everyone. I am Dr. Sanjeev. So basically, I'm an orthopedic surgeon. Later on, like, I have special interest in healthcare IT, basically clinical informatics, and now into artificial intelligence. So I just want to talk about like what's happening, the real scenario in Nepal, basically about artificial intelligence. We have been listening and everything is artificial intelligence right now. So either you like it or not, I mean, you are using artificial intelligence. That is the global trend, I think. So I'm going to talk something in about 10 or 11 slides, the real scenario of Nepal. So it's not that much developed, so don't get, that's wow, you guys have nothing, but that's how we are, I mean, right now. So basically, what's AI like? What I think is like AI means like cutting the human brain and pasting it in computer, so that computer it starts working like a human brain, but very fast. So it doesn't get distracted or something like that. So there are a lot of use in artificial intelligence, basically like diagnostic, like radiology. So most of the agents and tools are in radiology. So FDA approved, like the time I researched was like about 800 of federally approved radiology agents. So, I mean, we have been using like in predictive analysis of disease outbreaks, patient deterioration. Personalized medicine is another thing I would like to emphasize. It's like patient-centric quality care at genomic level. So basically, the same medication may not work in the same two different persons. So at this time, so the personalized medicine at patient-centric care is another revolutionary idea, and it's coming up. So robotic surgery, they say, but it's from 1990s. So 1990s robotic surgery and the current one is a little bit different. So in Nepal, we do not have that in rural area, but we have robotic surgery in only one, I think in BNB hospital. Right? So, but I think we are planning, I mean, with our like digital health platform and other with the help of telehealth, and with some foreign donors, some friends like from America, So we may be able to do some robotic surgery at the rural, health care systems also, and virtual health assistance as well. So if you go back, artificial intelligence is not today's work. So it has been from long time back, since 1950s. And there was mycin for infections. In 2000, IBM Watson. We know about that. And in 1980s and 90s, we had machine learning. Most of that was in medical imaging and X-rays and all this. So now, till present, it's like FDA-approved algorithms, tools like NLPs, electronic health records. So there's a lot, but this is very simple, summary, what I would like to talk. And before going details into the artificial intelligence or Gen AI, whatever you call it right now. So let's see, in the poorest country of the whole world, artificial intelligence, there are a lot of challenges. Most of the challenge is it's not only lack of specialists, basically, or infrastructure of connectivity. When you use AI tool or agent, what you call it takes a lot of energy. And even we cannot afford to buy one simple computer because our simple computer does not work. It doesn't take. It's not that fast if we start work. Using the best of the tool, artificial intelligence tool. So, do we have money? So that is one of the challenges to buy a computer itself. And our government wants to have all the data in Nepal, building basically the data center. So building a data center for this much population, it's like huge cost. So like I calculated building only a data center in Nepal for artificial intelligence use cost like 3 years of our whole budget, Nepal's budget. So are we just imagining or where we are? So having a specialist infrastructure connectivity does not help. A lot of energy. Where do we get that energy? Where is the electricity? So currently, even the Meta is struggling having a data center. So data center is very important, and having our own internet. That's the policy of government. So they want everything inside Nepal, all data. So in this world, today it's in the internet. So how can we have our own internet, not connecting with the outer world? So there is a lot of controversy going on with our current policy, So it's a lot of heck of challenges in Nepal. So still with our telemedicine team, and with Swasthya AI for rural diagnosis, there are some, person I say, who is taking lead and trying to advocate telemedicine and AI. So there are, some in remote villages, and there is one company called Pilatech, and they are using AI-powered apps, mobile apps, but still that's very expensive, and it's not that much, it's not certified. So uncertified AI-powered mobile apps, without any statistics or without asking anyone or taking government's approval. So people are using, but where the data is, basically we need data, right? Even the trend, so standardized data. So where is it? So there's a lot of controversy and it's haywire. So nothing is in one place, but we as a team in Digital Health Forum and telemedicine, and there are few, companies working for the government and working to develop some artificial intelligence tools in Nepal, but we don't have data. So buying a data, for example, only for Alzheimer training, it costs like 20 to 30,000 dollars only to train one. So that's exam. It's extremely, extremely, I mean, hard for us because we are poor and we don't have money. So how can we have a data set in training any AI model? So these are challenges. But, so data driving AI in healthcare. So we are using electronic healthcare. I mean, health record, but the problem is that we don't even have EMR in Nepal. Most of the EMR, what they called, are only revenue cycle management. So it's only manages like the money part. So clinical data, we don't have. We may have, but they are not standardized, no standard. So standardization means like all those, the fire and HL7s and SNOMED and low inclusivity, all those things. Unified modeling languages, basically we have been trying, and with the help of WHO, developing all those things. We just developed like standard operating procedure with the help of WHO and Ministry of Health and Population. So we are still trying hard, very hard, and X-rays and MRIs for medical imaging. So most of the data is, and most of the federally approved, FDA approved algorithms are from the medical imaging. But now we don't even have PACS system in our country. So how are we going to get all those data? And we are now thinking of AI, and I'm talking about AI in Nepal and rural health. So I don't know. So I need help. So but still trying it. So wearable devices, like, we have all Apple Watches, and from there also, we can extract data, and that data can be converted into standardized data, and that data we can use it, for so many things, patient-centric quality care, for example, or predictive analysis of something. So, and another is genomic data, and so everything is genome now, right? So with quantum physics and quantum mechanics. So basically, these are a lot of challenges. Data privacy, bias, interoperability, we are having hard time because what I have seen in Nepal is data privacy are only these two words, but there's no rule and regulation to catch all those things. So basically, nothing is licensed. Basically, we don't even buy Microsoft Word or Microsoft Office. Everything is hacked and everything is like cracked. So when we use cracked version, so how do we think about data privacy? We are all nakedly in so anybody can hack us. So that's also because of being poor. But I have been advocating, telling the government every time, telling the authorities, hey, it's possible, man. You can use, you can buy the licenses. Even Bill Gates, he bought Microsoft Office with $50,000, and that we are cracking and using it here. So it's not okay. So there's no data privacy. So a lot of bias and interoperability. Forget about it. So we may get hacked anytime. So these are the things we are suffering in Nepal. So pros and cons of AI, faster diagnosis, reduce human error, availability, cost, cons. Right now it's initial cost, so privacy concern. So there's a lot of bias in algorithm also. So even in the United States of America or the developed world, they are having hard time in making a policy. Because when they make a policy, then the developers of AI, they are having hard time in developing all those AI algorithms and models. So still at infancy. So basically AI is like autistic children right now. So it needs to learn and learn and learn. So a few examples of FDA approved AI tools, like, for diabetic retinopathy and for cardiac it's the caption AI and radiology, Zebra, medical visions. So I think I have seen my friends using these in America, because I implemented like 40 different EMR in Washington DC area alone. So they have been using this for the last 5-6 years. So I got these names because this has been used for the last 5-6 years. So in Nepal, I have not seen. So we are planning right now in advocacy. So global policy and regulation, there is a big question mark. You know, the HIPAA is an act. So basically, I won't say that regulations. So Europeans, GDPR and FDA's guidelines are also not that clear. Even, I mean, I think a few weeks back, I read in New York Times about this, the struggle to, pass the policy in AI. Still they're fighting, even in the developed world. So you can imagine what kind of policy we have here in Nepal. So basically, still, the Ministry of Telecommunication has taken care of writing a policy. Still, that we can see in the website of Ministry of Population, but that is like a very textbook model of like cutting and pasting and translating into Nepali. So basically, that does not fit our environment right now of artificial intelligence. We are still in very, starting phase, basically. Needing help in all the writing policies also. So privacy concern, I already talked about all those licensing things, and having all a data center in Nepal, and need of Nepal specific AI healthcare policies, but we do not have Nepal specific AI healthcare policies, but we have AI policy as a whole, but that also in infancy. So this is another struggle for Nepalese healthcare, not only in the urban areas, but you can imagine what is happening in the rural areas. So future, talking about, we're talking about predictive analysis, quantum computing. Quantum computing basically is not only 0 and 1. So there's third thing called quantum. So it uses qubits. So it's a little bit of more than bytes, 0 and 1. But I want everybody to look at the quantum computing. It's superb. So we're still thinking at our digital health forum about that. AI-powered drones for rural medicine delivery. We can do that in Nepal mountain region. So we are talking about that also. So this is very possible. AI-powered drone, it's not expensive. We can do that. So we have to make a framework, ethical framework. So ethics is a big thing, because they have said that the atom was developed by Einstein, but people, they created atom bomb. So now what with AI, artificial intelligence tool, it was tool before, right now it's an agent. So tool means you have artificial intelligence tool in your basement, so you can turn it on. But right now it's agent. Agent means you walk with Einstein, so it's with you. So basically information is in everyone's hand. So now how do you control everyone? What if even that tool or agent you have trained does not follow your order? So it's getting a human consciousness. It's called a coming wave. So it may take over the government. It may take over the politics. It may take over the finances. It may take over the our healthcare. So there's a lot of ethical dilemmas, and it's very scary also. Hey, be careful. It's not only taking your job, and even they have developed like the artificial intelligence tools like nanobots has been here. So nanobots means like in the next 5 years, if you do not die for the next 5 years, then you may live forever. So these are the things has been developed. So right now you can even correct the gene, like Down syndrome, that with the CRISP, you can use that and correct that, trisomy, that the 21 chromosome, etc. You can correct that also, Down syndrome. So Japanese has done that. So a lot of things you can do it. You can even clone a human being. So what happens if they make 10 of you? So who is going to control? So these are the things, ethical things, and a lot of things to think about. Not only just think about AI and okay, I'm selling these things that they're being back. So quantum computing and energy. I already said that a lot of energy, a lot of water is used. How are you going to cool that? Do we have that much efficient system? So where are you going to make a data center? So people are fighting right now, because like if you have your data center in a village where there is a lot of water and everything, and it's using all the water, so people are fighting and they're not giving place to make that data center. So in Switzerland, what they did was that there is a climate change right now. So climate change is basically the mountain is like melting down. So what they did was they made a dam. So underneath that, they made a data center. So it's cooling down using that icy water. So that's one of the models. So I don't know how we are going to have that much amount of energy to use artificial intelligence data center. So it's a lot. So it's impossible to have artificial intelligence and data center and energy at the same time. So things to think about. It's a lot of drug is coming right now using AI tools, right? So China has right now, developed that antibiotics. The antibiotics are custom made, so there is no antibiotics resistance. So right now we're struggling with antibiotic resistance and all those things. But right now what China is doing is that, okay, individualized at microbiology level, at the level of the mitochondria, where citric acid cycles and all this energy is being developed. They are attacking at the genomic level, at DNA, so that they find out exactly your digital footprint and make that antibiotics and give it to you. And there is no antibiotic resistance. So much things is going to happen. And now we're in Nepal, and now we are like talking about no money and thinking about helping poor people in the rural area. So there's a vast difference in between what's happening today and what is happening in Nepalese healthcare. So this is a big question. I'm going to leave it to the podium. And we can even optimize treatment plans in seconds, like I just gave example of the antibiotic resistance, which Chinese are using it right now. So takeaway is, what can we say? So it's transferring healthcare globally, including in Nepal's rural area. So I do not have any data of Nepal, but we are still trying, we are advocating, but we are doing telemedicine team like Dr. Uday and his team. So hats off to Dr. Uday, so he's doing a lot. I just joined them. So investing money. So who's going to invest? The public-private partnership is happening right now. So future with AI and quantum, would solve complex medical challenges. So thank you. That's it.
Thank you, Dr. Sandeep, for such a collaborative presentation on AI, this present scenario and future scenario, of course. First, I would like to request Dr. Nitin, and then we'll go on discussion. Dr. Nitin Bandari, will you please introduce yourself and start your presentation?
Actually, I had a small question, Dr. Udit.
Yes, because we are running out of time, so the venue may close.
Oh, okay, okay.
And maybe we can discuss after Dr. Nitin finishes his
Sure.
presentation.
Sure.
Thank you. Thank you.
Just give me a moment. Can you please confirm that you can see my slides?
Yes, we can see your slide, but it's not slideshow yet.
Okay.
Slideshow, yeah.
Let me try that.
Yes, it's slideshow. Thank you.
Perfect. Thank you. Hi, everyone. Thank you for the opportunity to present here today. My name is Nitin Bhandari. I'm a public health physician currently based out of Kathmandu, Nepal, and I'm also a digital health implementer. I'm currently working as the head of the programs for MEDIC. So before I go forward and talk about what we do in Nepal, I'll just introduce briefly about MEDIC and and the way we work. So MEDIC is a nonprofit organization, headquarters in the United States. We have 3 regional offices, and one is Nepal, East Africa, and West Africa. So, like I said, we're a nonprofit, and we work to strengthen the community health system to achieve universal health coverage. And we do so by supporting the community health workers in strengthening the community health information system. MEDIC is a technical steward and primary contributor to the open source platform. It's called the Community Health Toolkit, CHT in short. You'll hear about that a lot in my presentation. So we're a very small team, 60 plus staff from 20 countries. Now, moving on to the global impact. We're working in this country, including Nepal and in Philippines. We're trying to expand to 2 or 3 more countries in the South Asia region. We have so far around 170,000 users, and these are all community health workers. Now, I would like to introduce and talk briefly through the Community Health Toolkit. So Community Health Toolkit is a collection of open source software and open access resources. When I say resources, it includes documentation related to design, technical, and implementation guidelines. We also have a community forum, which is entirely community driven, and for the implementers or the practitioners of that want to deploy CST in their country or in their area. So it's not only for practitioners, it's also for the government to join. So anybody can join and be a part of the community. So CST can be easily integrated with various different platforms, including OpenMRS and DHIS2. It's the platform, like I said, is for the community health workers. So it is offline first. It supports multiple languages, including the Arabic. Works in basic phones, smartphones, and also in computers. Supports multiple hierarchies. For example, the Ministry of Health Nepal has a different hierarchy, and the Ministry of Health in Kenya may have a different hierarchy. So it supports also all different hierarchies. And this is some generic features of Community Health Toolkit. Number 1, it helps the community health worker to maintain longitudinal profiles of the community members, the household, and the family members. You can also enter demographic profiles, health-related profiles,
every profile will be maintained within a household, and that comes under a community. So there are inbuilt care guide for decision support for community health workers. These care guides are based on national protocols. So each country has its own protocols. For example, for under 5 sick child assessment, the Ministry of Nepal has endorsed a protocol and a guideline called the IMNCI. Similarly, the same protocol in the Africa region may be known as ICCM. So it supports all sorts of guidelines. The other function is the task function. This task function is very important for the community health worker because it guides the community health workers and it tells them on what to do, when to do, and how to do. For example, the community health workers may need to visit different households on a particular day. So it basically guides which household to visit and who to meet and what to do and how to do. For example, how to do an assessment particularly. So everything is protocol guided. The other function is a dashboard function. It tells the community health worker on the target versus the achievement, and messaging that with the families and other health workers. So these are universal health coverage tracker services. CST supports all different use cases. There are even more. This is just an example. And it also supports digital payments, stock management, etc. So it's a comprehensive package for a community health worker. So our work in Nepal, we started working since 2012. I joined Medic in 2018. And so far, we are supporting more than 22,000, I would say around 24,000 community health workers in Nepal. We are deployed in all 7 provinces, and we're a strategic partner of the Ministry of Health. We have an MOU with the Ministry of Health, and we're supporting the federal government, the provincial, and the local governments. Nepal has 3 tier governments. We're working with all these 3 tier governments. So our partnership approach is we first look for an intake from the government. Once the government or the local partner shows an interest, we talk about the cost-sharing modality, where Medic, we provide them the technology for free, and we support in capacity building, high-level capacity building, whereby we train master trainers, and the responsibility of government, local, provincial, or federal, would be to lead, own, and finance the rest of the deployment. So we promote gradual government adoption, and we want the government to take the lead and be the owner of the system. So this is a deployment map. As you will see, they're different color coded. For example, like all these provinces, they have different sets of health challenges, and CST has been used as per the requirement. For example, if you look in this Gandaki province, they're facing high maternal mortality rate, and they wanted a solution where they wanted to track each and every pregnant woman or pregnant mother. So CST has been deployed here, but it's only tracking pregnancies. In the case of Lumbini province, they have high maternal mortality and high child mortality. So they wanted a system whereby they wanted to track maternal health and child health. So the services that the Lumbini province is using includes the baseline assessment, that is household profiling, antenatal care, delivery, immunization, and nutrition assessment services. So these services are offered by the community health workers at the household level. Similarly, we're also working with the Nursing and Social Security Division that comes under the Department of Health Services, Federal Ministry of Health, and they have started a new program or a new initiative, contrary to the traditional volunteer-based, what we call is female community health volunteers. They have started and piloted a new cadre of health worker. They're called the community health nurses. These are trained, professionalized, and incentivized nurses who provide services at the household level. So, and the services that they are currently providing are listed on the right side of your screen. So these are the interventions from family planning, ANC delivery to child health, immunization, nutrition, mental health screening, cervical cancer, breast cancer screening, hypertension, diabetes mellitus, geriatrics, etc. So the idea is to provide comprehensive care to the household level. What traditionally used to happen was health programs at the community level was very verticalized. So there would be one health worker visiting a household, providing services to one particular member of the house. But contrary to that, the community health worker are providing comprehensive care to the household. And it's not a one-time service, it's a continuum of care. So once a community health nurse visits the household, she will also make sure that she'll visit the household after 5 or 6 months or after a certain interval of time. So the community health nurses are first designated an area, then they create a digital profile, then they provide these sort of services. So what the app does is it guides her where to go, what to do, and how to do it. Everything is recorded, and she can do she can refer the patient, go for follow-ups, and everything is protocol guided. Like I said, it's based on protocol recommended by the Ministry of Health. So if you can see here, the community health nurse, she carries a tablet that has the application. Her supervisor, the community health officer, will get an analytic dashboard that will enable him or her to sort of supervise the community health nurse. Similarly, the dashboard would also be provided to the higher level officials, and the beneficiaries will receive automated messages. For example, if there's a time for a mother to go for an antenatal care checkup in a particular health facility, the mother will receive an automated SMS message just reminding and asking her to visit the health facility. So it's like a push and pull mechanism. For example, by sending messages, automated messages, it's trying to nudge the user's behavior, beneficiary's behavior, while at the same time, the CHN will also be pulling them to the health facility. And the whole thing will be tracked by using analytic dashboard at the higher level. So they would know who is visiting the health facility regularly, who is not. And based on that, they can appraise the performance of health workers, provide supportive supervision, or provide feedback as necessary. This is very similar. This shows the deployment of Gandaki province. Here, the system has also been integrated with OpenMRS and the EHMIS platform. Now, so how does the Community Health Toolkit, or CHT, support the local health system? For the user level, I think I've covered most of it all, but I'll just give you a refresher. It's offline first. So, even though if there's no internet, the CHN or the CSW would be able to use it. It will have a comprehensive list of the households. It's CSW centric, so it will help the CSW to carry out the assessment, screening, provisional diagnosis, referral, and counseling. So the community health worker will not have to remember anything. So there are very less chances of misdiagnosis. So the data that is captured is very dynamic, automatically gets updated, for example, age, and suggests, for example, if a child is, let's say, 15 months old, the application will basically guide the CHN about her immunization. But after a year, maybe the application will guide the CHN and advise her to go to that particular house for the nutrition assessment. Similarly, it will allow the community health worker to carry out longitudinal patient tracking. I talked about performance dashboard and the bidirectional referral. Similarly, what are the benefits for the primary level healthcare center or the health facility? So they will have a supervisory dashboard. They can monitor each and everything that's happening at the community level. They'll have a good understanding of the population health, and they can basically track patients and basically ask them to come to the health facility or plan their services accordingly. It enables them for predictive planning. And like I said, since the system can be integrated with DHIS2, there's less reporting hassle. And one important thing is the strengthening of PHC gatekeeping. What we see these days, like there's a huge, but the patient flow to the tertiary care centers is very high. to a level that the government health workers or government doctors cannot even cater to them properly. And one of the reasons is the failure of the referral mechanism or the primary healthcare gatekeeping. Having enough evidences and enough support system at the primary healthcare level would enable proper referrals so that the right patients travels to the tertiary care center and the rest sort of receives the needed services at the primary healthcare level. Since geo-mapping is also done, in case if there is an emergency, the health facility can also integrate this information with the ambulance service and provide the patient transport accordingly. So what's the benefits for the local, provincial, and federal governments? It's open source, it's community-driven approach, so it allows for cost-effective innovation and adaptation. So since we want the government to own the system and we build their capacity, it becomes sustainable in the long run. It's transparent. It makes them accountable because of the data. It shows performance so that higher level authorities can easily appraise the health workers and the facilities and plan for budget dispersal accordingly. And sustainable in the long run, basically. So the opportunity is integrating this electronic community health information system with the primary care level, primary health centers, and the tertiary care center will basically help us make sure that the patients are receiving the services. We can track the patient journey and make sure that the data is captured. And most of all, I think it would be a missed opportunity or it's an opportunity, I would say, that such sort of system will help to detect the hidden cases in the community, the iceberg phenomena that we talk about. That's all from me now. If you have any questions, very happy to answer them.
Yes, thank you, Dagni. So I think venue is going to be closed now. Yeah. So now we can start the discussion. So from venue, if you want to say something in the last minutes, Dr. Moriano.
Yes, just a moment, please. He's getting ready.
Right. Thank you for wonderful presentation. I really impressed what is happening in rural healthcare about the digital health. So I understand that I suppose integrating a various system to electronic medical record is a key to establish a very good healthcare system, especially in rural areas. So I suppose that it's a pity that Japan is too cautious about personal information protection and seems to be left behind in digital health, I suppose. So thank you so much for your wonderful presentations, and I really hope to meet you again at the next APAN meeting. Thank you so much.
Yeah, thank you, Dr. Moriano. Mr. Abhimanyu, yeah, you were asking some question to
just a couple of general observations, and thank you, Dr. Nitin. Truth and disclosure, both Dr. Sanjeev and Dr. Nitin are my mentors, very close friends. We have worked together, so the questions might be loaded, but yeah, here it goes. Dr. Sanjeev, basically, when we talk about AI models, obviously there's something behind them, and that's data. And behind data, there's always data governance. So we speak a lot about training models and so on and so forth. My basic question is, in Nepal, since most of the literature is still in English, are we kind of not focused perhaps on the right place? Maybe we still build the models as is and then have another training model for a training model and translate that to Nepali. So that was the main question about AI. And for Dr. Nitin, I think I know Dr. Nitin for a long time. He's done great work. He's made real changes on the ground, and I speak not as a friend, but as a very impartial person. Question for you is obviously, and we have spoken about this separately as well, the integration of data as it comes through the community, and as you would say, or Dr. Dev would say, it goes back to the community. It's complex. It's not simple. So as we're picking up data, and I too have worked in non-traditional encounters. How complex is this? How much of data, patient data, is relevant with time? And have you done any analysis on that? I mean, maybe 10 years ago, the same patient data versus 1 year ago. Is it just a simple linear line, or does it depend on the health program? And I just wonder sometimes, are we collecting too much? Are we doing overdiagnosis? So just things to think about, ponder about. I don't need an answer right now, but definitely something. But thank you so much. Thank you to everybody.
So about the number of data, I have been reading a literature, plenty of peer reviews. So it starts from 500 to like 300,000. So that much data has been used to train any model. So the people, they have trained with 500 also. So I don't know if anybody has any statistical numbers like and which data, but it does not. We cannot prove that more data means more training and best AI model. So that is not true. But only how you train, how you write an algorithm. So that is best. So currently, I mean, talking about your next question about Nepali language is a large language model. So it's like a kid. They say LLM is like a 7-year-old kid's brain. So, till 7-year-old, I mean, till 7 years, the brain is developing. So LLM is right now, like the neurons are all interconnecting and it's growing. So LLM is not even 7 years old. That's what they say. So it's growing. And as a whole, artificial intelligence tool or agent, they are still in infancy and they are like autistic currently. So they have not gained human consciousness. So time is coming that they will gain human consciousness for sure. They'll be like us. They'll start thinking. They will have their emotions. So data means not only text data right now, what you are asking right now. So your question is very vague. You're talking about voice data. You're talking about picture data. So you're talking about radiological data. So a number varies. So I do not have exact number, but I think we need a lot of research also. So I leave this to answer some, maybe Dr. Akhila can answer more, elaborate about these numbers and things to satisfy Dr. Abhimanyu. So I said what I knew. So thank you.
While probably I might not be able to answer the question exactly, what I would like to definitely leave the forum thinking about is that most of the data that the AI today is getting trained on is very Western centered data that is available. A lot of databases, all the fundamental foundational large language models are trained on the Western data itself. And also at the same time, we have limited availability of data contributing from the other parts of the world towards this. So when there is whatever the AI is being trained on, that is the kind of patterns that it will be able to bring out. When there are wonderful initiatives, like I in my previous talk, I was hearing about a lot of community health work that was being done at Nepal. I'm not really sure how much of that is going back as the data, which is going into contributing to further secondary research. And when there is a lot of research happening, then there is a possibility of the pipeline forming for the AI model to build on top of that. So I think we should have different data banks, data centers being created in different parts of the world, so that less of the Western focused data generation is happening, and then there is equitable distribution of the research and evidence coming from all parts of the world. And I would definitely vouch for doctors in India. We find very limited amount of time available for contributing to this, and there is also doctors who are willing to contribute to do this work in their day-to-day practice, but the technology given in their hands, the softwares that are given in their hands, are not made very simpler. So that's the whole reason for how we are trying to simplify the whole structure system that is created for them to enable this further.
Thank you.
Yeah, thank you, Dr. Nathan, on that for excellent presentation. I think that the toolkit that you have, one specific question I had about the toolkit is that you mentioned it can be integrated into the EHR system. Given that EHR systems can be run in so many different platforms, do you think that would be an obstacle somehow to be integrated into all the systems?
I'm sorry, I did catch your question properly, but I think you talked about the integrating it with the DHI system. Did I get that right?
Well, what I mean is that because EHR is run in so many different platforms, right? Windows, Linux, and others, that those are available. Given what you said that your toolkit can be integrated into the entire system, do you think all those operating systems would have some obstacle to integrate your system into theirs?
I'll try to answer your question. So CST in Kenya and Uganda, just two example countries, have already been integrated with the DHIS2 system. In Kenya and Uganda, CST is part of the National Electronic Community Health Information System. They are used by all the community health workers in Kenya and Uganda. And this system has been integrated first with the facility-based platform. That's an EHR platform. And that ultimately, the data collection and aggregation goes back to the DHIS2 system. In the case of Nepal, we have done that in Nepal as well. In Gandaki province, what we have done is we have not directly integrated CST with DHIS2, but on the request of the Gandaki province Regional Health Directorate, we integrated our system with the EHMIS platform. So all the pregnancy-related information that is collected in the CST gets first to the EHMIS platform, and that information will ultimately goes to the DHIS2 platform. That's how it's been done. Our other work that is with the Nursing and Social Security Division and with the Lumbini province is also in plan to get integrated with DHIS2 system, but not immediately, because we're not responsible for the integration. It's the government's job that they are the one who should be initiating. We will be supporting them and doing the needful, but not the one to initiate that. Limitation in our scope. Yeah.
Thank you. So, is there any question or comment or? So maybe we are already running out of time. So we should say goodbye. It was very nice presentation, and thank you all. So we'll meet again.
Thank you.
Goodbye.